So, welcome everyone to Family Medicine Grand Rounds on a frigid Monday morning. And I just want to note our speakers today are joining us from California. So, they are really brave souls to be up and presenting at 5 a.m. their time. And God knows what time they got up to get ready to present. Um, Also, this is one of our special family medicine grand rounds. We worked with Kara Feldman Hunt and University of Vermont Integrative Medicine to bring a series of lectures that are endowed by the Laura Mann Integrative Healthcare Lectures. And Laura Mann, I just need to explain, is a nurse or was a nurse midwife. And when she was diagnosed with stage 4 breast cancer, she integrated Western medicine with complementary and alternative medical therapies. And despite her untimely death, Laura's vision is alive through the endowed Laura Mann Integrative Healthcare Lecture Series. This lecture series brings distinguished lecturers and leaders to the University of Vermont to share best practices, research, and innovations in integrative health and medicine. For more information on the series, or if you want to see past presentations, you can visit uvm.edu, Integrative Health. So thank you very much to Laura Mann's sisters, and I think they're both online, for bringing us this, wonderful opportunity to share integrative healthcare with our family medicine community and the broader community. Our speakers today are, as I said, joining us right now from California. We will have Elizabeth Markle, or Liz Markle, PhD. She's a licensed psychologist, researcher, and assistant professor of community mental health at CIIS, dedicated to multi-theoretical and multi-level approaches to individual and community health and healing. And her research is focused on social support, social capital, and social sustainability in the context of intentional community. Liz received her doctorate in counseling psychology from Northeastern University and her MA from Pacifica Graduate Institute. Our second presenter is Ben Emmert Aronson, also PhD, a psychologist, researcher, and advocate. He earned his MS in statistics from Columbia University and his PhD in psychology from Boston University. He co-founded Open Source Wellness. It's the first behavioral pharmacy, providing structure and support to fill the behavioral prescriptions that doctors give patients: to eat healthier, exercise more, reduce stress, connect meaningfully with others. And these 4 ingredients are necessary components to living well, and Open Source Wellness is creating a world where it is as easy to access them as it is to walk into McDonald's. So without further ado, I'll let you two take it away and explain how we might start writing behavioral prescriptions in Vermont. Thank you.
Thank you so much, Whitney, and thank you, Kara, for bringing us. Yes, it is in fact warmer here and also darker out here. So we're going to do our best to be alive, awake, alert, enthusiastic, and I'm going to share my screen with you here. So just a little roadmap for where we're headed today. I'm going to share a little bit about the origins of open source wellness, what we're up to. We'll share some video footage of what it actually looks like in action, both in person and virtual. Ben will talk a little bit about data outcomes. He's our resident statistics geek. We'll talk about how you implement this work in federally qualified health centers and other settings. And then I hope we can just have a little bit of a conversation. So as questions come up, please don't hesitate to put them in the chat. Ben may be able to answer them as we go, or if not, we'll save them up for conversation at the end. So the only disclosures to report is that, that Ben and I are co-founders and employees of the nonprofit Open Source Wellness, but we're run by a board of directors, so there's no profit to be made anywhere. And then, I'm going to start, but not spend any time on the things you absolutely already know, which is that chronic, progressive, and preventable health conditions are driving tremendous human suffering and skyrocketing health costs. So as a family medicine division, none of these statistics will surprise you, nor will the fact that during COVID, all of these have worsened. So I think it was the McKinsey report that 60% of adults are depressed, anxious, or both. and fully 1 in 4 are reporting binge drinking. So our work is cut out for us now more than ever. And I want to just share sort of where open source wellness came from. As Ben said, he and I met in Boston when we were both trainees in graduate school. And we did a lot of our clinical rotations in integrated primary care behavioral health. So both in giant health systems and teeny FQHCs, we supported patients, but also providers with the behavioral aspects of their clinical care. And he and I started keeping track of what we now call behavioral prescriptions. Back then, we just called them things that doctors tell their patients they should be doing. And here's what we found out when we started keeping track of all the curbside consults and the quick sessions and the long-term work that we did with patients in the integrative health context. First of all, no matter the patient's diagnosis or diagnoses, because comorbidity is the rule, in fact, not the exception, no matter the diagnosis and no matter the provider's identity, whether this was a resident, a senior provider, primary care, specialty care, behavioral health, case management, et cetera, we found that most patients were receiving one or more of the big 4 prescriptions. And they are, if we could be in person, we would just crowdsource this because they're not rocket science, but they are: number 1, you should exercise more. Number 2, you need to eat differently. This is my favorite: reduce your stress. And number 4, get some social support, or you need some meaningful, authentic connection in your life. Now, I don't know about you, but these are actually pretty good, right? The evidence actually supports these 4 behavioral prescriptions. Here's the part that would make Ben and I kind of claw our hair out, is that the provider would verbally deliver these instructions, and then they would say something like, good luck with that, I'll see you in 6 months. Off you go, take care now. And over time, Ben and I would sort of stare at each other and think, wow, if we wrote a prescription for antibiotics or antidepressants or insulin and said, good luck finding that, take care now, it would be malpractice. So all of this is to say that when we write a prescription for medication, we know we are relying on a delivery system, a nationally democratized and developed infrastructure for the delivery of the treatment, not just talking about it, but actually getting it to the patient, right? If you write a prescription for antibiotics, you don't say good luck finding them, you say, what's your closest pharmacy again? And you know that there's going to be a pharmacist that will help them know how to take the medicine, that their insurance will cover it, and that they'll get roughly the same treatment no matter who they are when they walk into that pharmacy. All right, all of this rant is to say there is no such infrastructure for behavioral prescriptions. And in fact, what we see is a divide along lines of privilege. If you can afford Whole Foods and hire a health coach and take up Pilates, if your neighborhood is safe for walking, if you have access to fresh, healthy food, you have a shot at these. Not a guarantee, but a shot. But for the patients who needed it most, what we saw is that they said things like, okay, yes, doc, yep, I know, I should, I'll do that. And then they went home into the same systems and structures that made it impossible for them to manifest these in the first place. And we saw them in our emergency department 3, 4, 5 weeks later. So without sounding too misanthropic about the healthcare system, I want to say it's not the provider's fault, right? These are in fact the appropriate prescriptions to be naming. We just don't have a delivery system to fulfill on them. And that's what we set out to do with open source wellness. So in 2016, Ben and I left clinical practice to found Open Source Wellness. And our vision was to create a behavioral pharmacy that delivered on this universal prescription that we abbreviate to be move, nourish, connect, be. These 4 things. We said they help almost everybody, they hurt almost nobody. And when we did this, we had a couple big commitments in mind. First, we said this work has to be experiential, meaning no more telling people what to do, no more handouts, no more verbal prescriptions, not even apps that remind them to do it. We said we're actually going to do it with them, and we're going to make it fun and socially rewarding. And this came in many ways from our time. We both trained at the VA for a period of time, and we were talking to our patients about physical activity and social connection. And I remember saying to Ben, if I could just meet these patients at 8 a.m. for a walk 3 times a week, they'd have a better shot at it, right? What if we could just do it together, the thing that I'm encouraging them to do? So at Open Source Wellness, we do that. It's experiential. It's transdiagnostic. I think we made that word up, but you get the gist. We don't have a diabetes group and a depression group and a hypertension group because frankly, we all need to be practicing these basic underlying drivers of well-being. So we have the humans who have both strengths and challenges in their well-being group. That's who comes to our groups. Lastly, it's comprehensive, meaning it's not a la carte. You don't sort of pick like, oh, I just want to take a physical activity class, but I don't need these other things. We actually have everybody do everything, including our coaches, our interns, our team. We're all kind of in it together. And we do occasionally get pushback on this from patients. Somebody will say, well, I just want help with nutrition because I want to lose weight, but I don't need this social support or stress reduction. Or patients will say, I'm just struggling with depression. I need the stress reduction, but I don't, why do we have to do movement? And we say, I hear you, and like, give it a try. Join the group. We're going to make it fun, and then we'll see what it's like for you. And often what we find is that, the person who said, I'm just struggling with depression actually finds that the physical activity is a better intervention for their mood than the stress reduction. Or the person who says, I just wanted to look at my eating behaviors, finds that the mindfulness helps them get some insight into how and why they're eating, right? What are the emotional drivers of their relationship to food that make a difference? So we stand by experiential, transdiagnostic, and comprehensive. And lastly, we said this work has to be democratized, meaning we can't replicate the boutique wellness industry, right? We don't need another Pilates studio that's accessible to those with financial capital and sociocultural capital, that this has to be baked into the healthcare systems so that it accesses those who need it most. All right, so that's the gist. I imagine you're wondering what it looks like. I'm going to show some photos and talk through kind of the patient journey through the experience of open source wellness in a clinically integrated setting. So all of these are pre-COVID. We'll show you what the virtual world looks like afterwards, but trust us, we're not dancing around without masks these days. So the patient journey often starts with a provider prescription. And a doctor might say, I'm going to write you a prescription, but it's not for medication, it's for participation in a community. That's sort of the opening line that we train our providers to start with. And then they describe what happens at Open Source Wellness. And the providers know because they've done it. So whenever we launch a new clinical partnership, the first thing we do is an all staff event where the entire clinical team, including the MAs, the front desk, et cetera, participates in an Open Source Wellness event. And here's what happens. So they prescribe a patient in, and as soon as we get that patient's name and phone number, they get a phone call from an open source wellness coach. And this is not like an administrative reminder scheduling call. This is a relationship building conversation. They spend 15 to 20 minutes on the phone getting to know each other, and the coach is trained to really access what matters to this patient, not what their doctor sent them there for, although they also want to know that, but what hurts for this patient and what it is that would make their life better. So after that conversation, they get the patient set up to join a 16-week cohort. They get them all set up with where to go or how to sign on to Zoom. They might spend 20 or 30 minutes training that patient to use Zoom if they've never done it before. So they'll walk them through the download, teach them the mute button and the video button so they feel really confident when they join their first 2-hour session, and that happens weekly for 16 weeks. And in those 2 hours, Move, Nourish, Connect, Be is what happens. So we often start with an icebreaker, and then we get right into about 20 minutes of fun physical activity. And as you'll see in some of these photos, we're going for laughter and connection just much as we're going for sweat or physical activity. After that, the whole large group transitions to about 5 minutes of some sort of stress reduction. It's dogma-free. We're not teaching any particular tradition or practice. We're just giving people some sort of muscle building and practice in going from high activity, external focus, interactive to quiet, internal focus and down regulating of their nervous systems. At this point, the large group transitions to what we call a spark. We used to call them lessons, but we realized they're actually more interactive and experiential than they are instructive. But the whole group will engage for 10 or so, maybe 15 minutes around a topic that's related to one of our 4 pillars. So example sparks are like cooking healthy on a budget, or setting boundaries in interpersonal relationships, or how to weave stress reduction in even when you have a busy day and you're taking care of kids at home. Every coaching team is empowered to select sparks that really are aligned with the needs of their population at a time, and even to create new sparks. So sometimes a coaching team will say, you know what, this group really needs to talk about sleep. That's what we're hearing from them. And they will draw from our spark library or even create a new spark that will really address the needs of those participants. After that, the whole group, when we're in person, actually has a plant-based meal together. You can see that the large group splits into small groups, and they either have a meal, or if they're on Zoom, they might take a break and run to grab the meal that they prepared or just a snack out of their fridge. This is also when we talk a little bit about nutrition. Every week we do some little micro lesson around nutrition. And then every small group has about 45 minutes to have a conversation together. So you'll see these are tables. On Zoom, it's breakout rooms. And every table has 4 or 5, sometimes 6 participants, 1 open source wellness coach, and 1 peer leader who's a graduate of the program. And this is where the magic happens, because while it's not therapy, right? There's no clinician, there's no psychotherapy happening. It's highly therapeutic because they get really, really real with each other. They talk about their health and their diagnoses, but really they talk about their lives and their dreams and their hopes and their traumas and their challenges and their families. They really, really connect deeply. And the coach is trained to facilitate weaving that group connection, even among diagnostically and demographically very, very diverse groups of patients. So at the end of this connect period, we're coming towards the end of 2 hours together. A couple things happen. First, the coach supports every participant in writing their own behavioral prescription. So this is not doctor prescriptions, it's not coach prescriptions, it's participants writing their own prescriptions. And when we're in person, if you can look at my image, can you see this? We have these little prescription pads that every patient writes on. When we're virtual, everybody writes it down for themselves. And patients are empowered to write about what matters to them. So often we hear things like, I'm going to go for a walk 3 times this week, or I'm going to reach out to that friend that I lost touch with, or, I'm going to cook this strange bunch of vegetables that y'all gave me and, see if I can make it tasty. But we also hear things like, I'm going to floss my teeth every day this week, or I'm going to deal with my credit card statements. I've been avoiding them and it's time. And, at first we were a little perplexed by this. We said, wow, we're not teaching about dental health. We're not teaching about financial health. What do we make of this? And really what we found is that when participants start to get some traction in making and meeting goals that matter to them, they start to take on their lives. And that sort of building of self-efficacy and willing and empowered engagement in the things that matter to them, that brings us a lot of joy, right? Because that's sort of what matters in the world. Whether or not their A1C goes down by a few points or their blood pressure changes, seeing people empowered in their lives, that's worth the price of admission. So we wrap up the groups in the same way every time. So the large group gets back together and participants are encouraged to share gratitudes. So they might say, just raise their hand and share something they're grateful for. Some groups do offers and requests where they say, somebody might say, you know what, I've got a ton of cucumbers from my garden. Does anybody want some? Or, you know what, I need someone to text me at 8 every morning and make sure I'm up and out of bed. So they exchange offers and requests for support and resources. And finally, they make declarations. So they might read out their prescription for the week. They might say, all right, guys, like by the time you see me next week, I will have blank. And that's the end of the group. In between groups, every small group is on a text thread together. It's just basic SMS group texting. Nobody has to download a platform. That was sort of a challenge for many of our participants. And the coach, so on that thread, we've got a coach, a peer leader, and the participants. And there's just sort of a constant sort of chatter of support happening. So if a group is on Tuesday, Wednesday morning, that coach is going to be like, hey, Vicky, did you go for your walk this morning? Or do you need any support with those strange vegetables for dinner tonight? Or how to go reaching out to your friends. So there's a way of just keeping the conversation about self-care and well-being alive throughout the week. All right, I just talked so much. I'm going to pause and Ben is going to show us a video. We've got two for you. First, we're going to show you what open source wellness looks like in person. And you'll hear a little repetition of some of the things I just shared, but what I encourage you to pay attention to is, what do you see? What does it look like? What does it feel like? And afterwards, we'll invite sharers in the chat, or if you're welcome to just chime in, about what you noticed and how this is similar to or different from healthcare as you know it. All right, Ben, take it away.
If I had to describe open source wellness in one word, it would be opportunity.
I don't know a word that means healthy and fun at the same time.
I'd probably say community, but I might also say fun.
I'm Dr. Elizabeth Markle.
I'm Dr. Ben Emmert Aronson.
We're the co-founders of Open Source Wellness. Open Source Wellness is a behavioral pharmacy.
When I leave from a night at Open Source Wellness, I feel great. I feel free. I feel at peace. I feel cared for. I even feel loved.
We found during our time practicing as psychologists in big healthcare settings that healthcare providers are constantly making behavioral prescriptions. It sounds like move more, eat better, reduce your stress, get some social support. Unfortunately, doctors often then say things like, good luck with that, I'll see you in 6 months. We know that if we're going to make behavioral prescriptions, we need to have a delivery system or a pharmacy on the other side of that.
One of the things we talked about is goal setting.
The first goal I ever set was about my cigarette addiction.
So I made a commitment for 4 weeks to find a recipe and make it once a week.
It kind of came to me that what I really wanted to work on was what's inside, really my emotional well-being.
Today I made the commitment I will get up half hour after I wake up.
So at Open Source Wellness, we support patients with physical activity, healthy meals, stress reduction, and social support. And we do it in a way that is affordable, accessible, culturally relevant, and experiential, meaning we don't just talk about healthy living, we do it together in community.
When I get home, I don't even really want to smoke. And the whole time up here, I'm not even thinking about a cigarette. You know what I mean? It just, wow.
And I believe that the staff here really want to make a difference. They're young and they're energetic, and so they can keep me moving at a pace that's new for me because I have a sedentary lifestyle.
I was not having the same anxiety, I was not feeling the same stress, because the movement, the exercise, it makes you to feel better. So I really like it.
Liz and I both led enough of those classes that are like in a dark basement somewhere trying to get people to exercise more or to eat better, and telling them about it, telling them the thing that they're supposed to do. And then they go home and do exactly what they've been doing. We mostly do what's fun and easy. And so our goal at Open Source Wellness was to make the healthy decision the easy decision.
We've spent 2 years refining our program based on outcomes data, and we now have models ready for easy and affordable implementation in clinical healthcare settings, community-based settings.
All right, thank you so much, Ben. So yeah, that video was made a couple years ago, but it gives you a really good sense of what it looks like. So I want to just take a moment and invite reflection. You could unmute and share, or you could put in the chat, what do you notice about that? How is that similar to or different from healthcare as you know it to be? Care about fun and connected. Yeah, we're definitely going for fun. If it's not fun, people don't come back to groups.
I would just, if it's okay to jump in, I would just say that What I think is really wonderful about what you're talking about is it actually gives the patient agency in their recovery, as opposed to just having an authoritarian figure who is a medical expert looking at them and saying, okay, here's what you need. You either need this chemical prescription or you need to lose weight. The kind of top down thing, it brings the patient into their own sense of wellness and gives them advocacy.
Thank you, William. We're certainly trying.
It was really good to see the people expressing their almost joy and definitely pride at being able to set a goal and to be so excited about the goals. It wasn't work to have a goal. It was just, it flowed from that sense of connectedness maybe and community, the support, the wraparound of all of that for them. I really liked seeing that as that goal setting bit.
Yeah, thanks. Yeah, we really, oh, go ahead.
Okay.
Go ahead.
I'm wondering if part of the efficacy is because people are helping other people, so that it's a healing and inspiring, energizing thing right there.
Yes, absolutely. So we really are enrolling people in not just being the recipients of passive services, but being active co-contributors or co-creators to a community. We used to have a poster on the wall that said generosity, abundance, and contribution. And we really find that when people experience themselves as a contribution, they show up in an entirely different way than when they are just, showing up to receive something. All right. Well, thank you so much for your comments in the chat. This is amazing. Yeah, Kate, do you want to chime in? I don't want to miss you.
Thanks, Liz. What I wanted to say is I've been doing a lot of work with alcoholics, and just so people know that AA has gone online with Zoom. And I am tremendously impressed with anybody. And we've had a number of people be successful coming online with Zoom, and they've never met anybody. And that really talks to the power of community, whether it's through Zoom, but more importantly, in my mind, the power of AA. That because in Vermont, one of the things that's good for the state but bad for people is our tax revenues on liquor sales went skyrocketing. And that really tells you at a nickel and a quarter at a time for a bottle how much people are drinking.
Yeah, absolutely.
And so AA Zoom works.
Beautiful. Well, Kate, what an incredible transition. Here's what happened. We were diehard about being an in-person program. Everybody said, when are you going to make it virtual? When are you going to do an app? And we said, no, we're going to bring people together in person. And then March 2020 hit and we had a choice to make. And to our delight, it not only works virtually, it created access for a whole bunch of people who were not going to be able to make it into the clinic every week or even to a community space every week. So what we're going to share with you next is a video of what this looks like virtually. It continues to exist in partnership with providers, and it takes some doing of getting HIPAA agreements and getting forms filled out and all of that, but we are onboarding patients that we've never met before to the virtual environment. So I want to share with you, this is a video we made last March. So you'll hear some dates in there about people just getting used to this idea of what was happening with COVID-19. But again, I just will invite your reflections afterwards on what's working and what didn't work. So Ben, go ahead. We'll watch our virtual video.
Sure. I'm going to launch that in just 1 second. Before that, I just want to call out a few things from the chat. So there are a number of references to the whole person care and also, of course, to the focus on connection, which we really describe as our secret sauce at Open Source Wellness. And then there were a few questions about the financial aspects and does insurance cover it? We're going to be talking about that in just a few minutes here. So I want to let you know that that's coming. All right.
Welcome to the Wellbeing Hour. Today we're going to do those 4 big things that we do. We say move, nourish, connect, be. What is the best thing about being on shelter in place.
I had time to just go outside and look at the clouds.
I'm meditating more. That is definitely a good thing.
I can say that I have my exercise pajamas, my sleeping pajamas, and my daytime pajamas.
Yeah.
Here we go. Double. Double. Come on, Tammy.
Tú sabes cómo lo hacemos, baby. Baby, tonight's like fuego. We about to spend a dinero. We party to the extremo, baby.
So we're gonna settle into mindfulness here. I wanna just invite you to get comfy in your chair. Just settling your attention all the way down. Just noticing for a moment what's happening inside your body. I invite you to just receive the kindness and the affirmation and the perspective that this beloved friend might offer you.
I feel like what if things don't change? Like, what if this pandemic goes away, but everyone's still like so scared and everyone.
It just seems like we just don't know. So I don't even try to think about, I'm just taking one day at a time. I just like see what's going on today and don't even think about the 7th of April or Easter. Yeah. It's just one day at a time.
But I've had to cook for myself, which I normally wasn't doing, so the nourishment went up. Even on one side of my family, people were poor, but we still had plenty of food. So I've been a little upset about people hoarding because we don't have those type of problems, supply chain problems, but they're created those problems. And for the first time in my life too, I'm like, whoa, like I've never been afraid of food. It's a weird, crazy feeling, you know?
I'm still really structured with taking long walks, at least every other day. And so but what I notice is that on the days that I do walk, I feel great. And on the days that I'm at home, I'm like down.
These two girls that I walk with, we started walking before this all happened, and we went for some great walks down there at the San Leandro Marina that were fantastic for me. But now we can't walk together, so we walk and talk. There's 3 of us, and we take off, just in our own neighborhoods, we take off and go maybe a couple miles or so, and come back, and we talk the whole time to each other, and take pictures of different things we see, and send it to each other. It's kind of neat though, doing that, you know, it helps.
Anybody else want to just hold up their paper so we can see? I want to thank you for your willingness to be vulnerable enough to share. At Open Source here, we talk about truth, desire, and habit. See, wherever we start, it's got to be with what's true. This is what's true for me. And then we look at desire. That is, what do you want? How do you want it to be? I want to be feeling ease. I want to be eating in a way that nourishes me. And then part 3 is about our habits. It's like, how do we set up the habits that get us from what's true now to where we want to be?
Hi, everyone. My name is Rachel. If you don't know me, I talk a lot about food and nutrition here at Open Source Wellness. And so what I want to talk about today is one of my favorite snacks, which is the apple and peanut butter. And one of the reasons why I like to do apple or really any fruit of your choice with peanut butter or any nut butter of your choice is that it's like a mini meal. It's giving you the great complex carbohydrates, fiber, fluid, sugar in the fruit, but it's also balancing that with the protein and the healthy fats that are in the peanut butter so that it hits your blood sugar more slowly, keeps you fuller. All right, apple slice, it's about a tablespoon. So serving would be like 2 of these guys.
I'm grateful for the opportunity to slow down.
I was saying I was really grateful that technology is in a place that we could all be in quarantine, but still be able to be connected, stay connected like this as a group.
Well, I just wanted to thank you because this just met everything that I needed. Totally, exactly, including seeing all of you wonderful people.
Yes, grateful for family and wellness, and everybody finds something to laugh about at the end of the day. At some point in time during the day, laugh about.
Yeah. I declare that when I have hard moments this week, that I come back to this moment right now in my mind.
Bye-bye.
Bye, guys.
Bye, everybody.
Thank you, Ben. All right. So we're going to have a little more time for Q&A and conversations afterwards, but please don't hesitate to stick questions in the chat if they're coming up for you. That's what it looks like online. And what you couldn't see, and what I'll talk about later, is that in that virtual environment, people are kind of coming and going. You might notice there were different people in the frame at different time. And what's happening is that patients are being pulled out one at a time or two at a time if we have multiple providers to have short individual medical visits with a provider. And this is part of the billing strategy, but it's also how we are addressing the more disease specific or personalized aspects of care, right? Our coaches are focusing on global transdiagnostic well-being, and the providers that we're associated with are tweaking medications, answering specific questions. So we'll talk more about how that happens. I don't need to say this, but for anybody who's done health promotion or run groups, et cetera, knows that there's nothing rocket science about physical activity, healthy food, stress reduction, and social connection. And what I want to highlight about this work first is that it's highly experiential, as you saw, transdiagnostic and comprehensive, we talked about. It's culturally flexible, and we try to make it really turnkey in its implementation. So, we have Spanish-speaking groups in predominantly Latinx clinical areas here in the Bay. We have a group up in Washington State. We do low-income housing work with predominantly African-American populations, and every aspect of this program can be customized to the population. So the music is different, the movement is different, the food is different, the language used in coaching is different, the coaches we hire are different. So we hold to the skeleton, the move, nourish, connect, be, the coaching, et cetera, but every other aspect of this gets designed for the population. And lastly, we say it's powered by connection. And what we mean here is that the people actually running these groups are not licensed medical professionals. God love them, but sometimes we're trained to come from this sort of expert stance of telling people what they should do or what we know. We're actually hiring culturally relevant peer leaders and health coaches who are trained to lead with their own humanity, their vitality, their vulnerability. They're showing up with their fullness in a way that creates a very, very different group environment than a provider-led group of people kind of sitting in a circle and talking. All right, I'm going to hand it over to Ben here, who's going to talk through some of the outcomes data of this work, and then we'll get into implementation and funding, how we actually make this happen. So take it away, Ben.
Oh boy. So now we're in the data geek side, which is definitely my bread and butter. I love our work. I love seeing our work. And anytime I see a presentation like this, my thoughts always go, okay, it's a great story, but does it actually work? Let's see the numbers. And so for us, collecting outcomes data has been something that we've done from literally day one with open source wellness. We always wanted to know for our participants, how was their life changing? What was improving for them? And then also kind of organizationally, how are we doing? Are we accomplishing the changes that we think we want to? And then of course, to share that out to the broader medical and scientific community. We really have a focus on changing how healthcare is run. And we know that sharing out the outcomes is going to be a vital part of making those changes. So here you see some of the initial process measures that we're tracking. So diet and exercise, you can see people are increasing their daily servings of fruit and vegetables by over a serving per day. This is one that's particularly important to me. There was a meta-analysis that came out just a couple of years ago that showed if we if everyone in America ate one more piece of fruit or one more vegetable per day, we would save 30,000 deaths per year. So grab an apple on your way out of the talk. This is important stuff. You see an increase of a little over 45 minutes of exercise per week here. We also, as you'd expect, see real improvements in social support and in connectedness. So folks are significantly improving their social connectedness here and their overall well-being. This is the World Health Organization's 5-item well-being index, and we saw significant improvements there. We saw major drops in depression and anxiety and loneliness, improvements in mental health here. So this was from a subsample of folks who came in with elevated levels of depression. We're assessing that with the PHQ-9. And so for folks familiar, you'll know that 15, you're into the kind of, you're starting to reach the moderate clinical level here. Dropping down to just under 6 is almost considered normal mood. 5 is 5 and below is normal mood symptoms. So we're seeing drops of over half of both depression and anxiety on the GAD-7 there. Again, for blood pressure, this was a hypertensive subset. So folks who came in with elevated levels of systolic blood pressure. And we saw a drop of 21 points in systolic blood pressure over the course of the group. You know, this is larger than what we expect to see on antihypertensive medications, larger than what we're seeing in trials of antihypertensives. So we're really seeing those changes in diet and exercise, and then also that connection and support really paying off in some of our most common and also most costly diseases. And speaking of cost, we saw huge changes in acute care. So we looked at the 6 months before patients started our group. We did a big chart poll and looked through their charts for ED visits or unplanned hospitalizations in the 6 months before they started group, and then looked at the 6 months after they finished group. And what we saw here was that we was a 77% drop in acute care utilization from the 6 months before to the 6 months after group.
Thanks, Ben. So, you know, all of this at this point is pre-post. We're still working on the randomized controlled trial in partnership with UCSF and Stanford out here. So if we come back in a year or two, hopefully we'll have that data to share with you. I want to talk just a little bit about how this gets implemented and where. So in our conversation today, we're focusing on clinically integrated implementations of open source wellness. I'll just name that we do this in communities, in low-income housing, in corporate contexts for employees. And then sort of our pride and joy is the peer-run OSWX. So, you know, our groups are 16 weeks, and when somebody completes, they can just graduate and be done, or they can apply to be a peer leader to stay on. But there are invariably more applications for peer leaders than we have space for. And we a couple of years ago, we ended up with participants who were mad. And they said, you can't kick us out. This is what we do on Tuesday nights now. Or like, these are my people. So we supported them in starting what they call OSWX. So you know how there's TED Talks and there's TEDx as the independently organized version. OSWX is the independently organized, peer run, we're not liable for it, weekly gathering that used to be in person and now it's online, for graduates and participants of a program that want to keep doing what we did. So we have a group of leaders that take 6 months terms. It is sort of inspired to some degree by the AA model. And, you know, I'm reminded of a participant who, after his first week at Open Source Wellness, this is when I was still sort of running things, I was on the ground more, running groups. And on his way out, he said, Dr. Liz, is this like church for health? And I laughed and I said, oh God, no, this is not like church. You know, where'd you get that idea? And then, you know, later as the team debriefed and we thought about it, we said, you know, church is something you don't graduate from. Church is something you go to because it supports your well-being and it aligns with your values. So we're not church for health, but I love the idea that there would be self-sustaining, generative, ongoing maintenance groups that participants will engage with afterwards. So right now that's operational here in California. My hope is that as this spreads, more and more of those will get going elsewhere and in the virtual environment. So these are some of the partners that we're working with. Most of these are here in California, but not exclusively. And I want to just highlight one really innovative way this is being implemented or bundled as part of a broader clinic transformation initiative. So this is happening in Alameda County here. It's sort of Oakland, Berkeley, Hayward area, if you're not familiar with the Bay Area. And this is where the government anti-poverty initiative, they're called All In Alameda County, said, we want to move the needle on health. And we're going to do it by bringing 3 big interventions to wrap around a clinic. So open source wellness is the lower right. It's sort of the blue behavioral pharmacy component. The green up top is a food as medicine or food pharmacy component where participants are receiving food prescriptions. That's actually delivery of regeneratively, organically grown produce to their homes every week, along with recipes that kind of goes with the open source wellness intervention. And then the lower left corner is a social needs pharmacy. So this is a way of sort of assessing and referring to social determinants of health that are related to the chronic conditions that our participants are experiencing. So while open source wellness can be a standalone intervention, we love partnering with other groups that want to sort of bundle or stack interventions together. Okay, so let's just talk nuts and bolts. I know many people are saying, first of all, do you need a whole lot of tech money? Like, do you need grants? Do you need to be in California to make this work? The answer is no, but I'm going to talk about how this works when we partner with a clinical entity. So when we're doing this in person or virtual, the relationship is essentially the same, but I'm going to talk about the virtual environment because that's where we are. When we launch a partnership, OSW agrees to provide the facilitation of the entire program. So when that's virtual, that means we're going to provide Zoom and we're going to kind of drive the Zoom platform. We're going to facilitate the groups. We provide the coaching and the support. Importantly, we provide the patient engagement. So we make the phone calls, send the text, get the paperwork signed online. We onboard patients to Zoom, and we gather all the outcomes data and do this sort of analysis and reporting. And what we need from the clinic is one clinical provider for the 2 hours that our group is run, who is going to see patients in a pull-out basis, one by one, doing short 5 to 10 minute medical visits over the 16 weeks. They are going to do the charting and billing for those patients. And then we need the whole clinical team to be making referrals or prescribing into the open source wellness group. Now, part of what happens is because we're transdiagnostic, we get a huge referral funnel, right? Behavioral health can refer into this. Chemical dependency can refer into this. Primary care and specialty can all be prescribing into open source wellness. So we don't have trouble filling these groups or creating retention in these groups because we're getting a lot of referrals. And then the open source wellness coaching team is providing so much support. It's so high touch, it's so relational that we kind of manage keeping the groups full. And then here's how the funding works out. You know, it's different in every clinical system, but I'm going to talk about how it works out in one of our federally qualified health center partners, because they are the ones that have no extra resources to spare. They cannot just provide something that's nice for their patients. Here's how this has worked out here. So I'm going to talk through this. If this is not interesting, feel free to ignore it. But here's what we found is that on average in a 4-hour clinical shift, this clinic was averaging 7.5 visits. Now they were booking 11 or 12, but the no-show rate was high. And on average, when we looked at the actual numbers, they were billing 7.5. The open source wellness groups are large, right? There's often 18 to 20 to 24 patients in the groups because we have a team of coaches. We keep about a 1-to-6 coach to participant ratio, but they're large. And the billing comes from the provider that's pulling patients aside, either physically in an office space or virtually using the breakout rooms function for those short individual medical visits. We average about 16.2 patients billed for an OSW group medical visit. So that takes up the same 4-hour clinical shift that a provider would otherwise. So for 2 hours with us, they're just seeing patients back to back, and then we block their schedule for the other 2 hours so that they can do the charting, place the orders, follow up on anything that came up that was big. So the upshot here is that that provider is billing about 8.7 more patients than they were doing just individual visits. You know, the reimbursement rate of the PPS system was about $250 for this clinic, which generated a ton of extra revenue that would more than cover the cost of contracting with open source wellness for a year. So they were clearing just about $27,000 extra in a year. They chose to route that funding towards produce prescriptions. so that in addition to the open source wellness program, patients were getting bags of produce sent to their home to really make a difference. But clinics, of course, have the opportunity to just keep that revenue and invest that in other programs. All right, I'm going to stop talking momentarily here. Just a couple closing thoughts. We're all familiar with the social prescribing movement. And at Open Source Wellness, we're looking to just take that one step further to say, what if we were not only the prescription, but the delivery system for that prescription as sort of, another version of an integrated care delivery system. And, as we talk about this in the field, part of what we want to uplift is that we all know the risk factors. We call them SDOH, we call them community determinants, we call them whatever we do. And then we know the likely outcomes clinically and socially that are correlated with those risk factors. And part of how we see open source wellness, or what we call experiential medicine or community as medicine, as a wedge between the risk factors and the likely outcomes, right? We are not as far upstream as creating employment opportunities, addressing structural racism, fixing the food chain. We are sort of a midstream intervention. We're not downstream clinical care, but we're trying to kind of get in the middle and create a diversion or another path here. This is one of my very favorite quotes in the world. James Rouse says, "A community is a garden in which to grow people." And the way I think about this is that, if any of you are gardeners out there, I know it's the middle of winter, but in the summer, if you're a gardener and your fruits and vegetables or your flowers are not growing well, you probably don't shame or berate the flowers, right? It's not like, what's wrong with you? Why aren't you looking great and thriving? We would say, what's missing in the environment that would have my garden thrive? So part of our vision at Open Source Wellness is to create the environment, not only physically, but socially and psychologically, that has thriving be the natural expression of humanity. And everything we do is designed to create an intentional community or a microculture in which vulnerability, vitality, joy, belonging, all are the default. So at Open Source Wellness, we say community is medicine. As Ben said, we do feel that it is the active ingredient or the activating agent that takes something that's inherently not rocket science, physical activity, healthy food, stress reduction, and animates it into a powerful intervention. So I hope you don't hesitate to be in touch with us. By virtue of what we're doing virtually, we're able to partner with clinics all over the place. And we love just having conversations about what's possible. So whether you're a federally qualified health center, whether you're in the community, whether you're in a bigger hospital system, we love having conversations with people about how we might be able to partner. Okay. I'm going to be able to see your faces for a moment. Let's have a little bit of a conversation. So Ben, you may be tracking the chat and what's most alive. Ben, is there anything that you feel like we really need to address here from what's been raised already?
I've been typing furiously. I think most of them got answered. I'm seeing a number of questions about the logistics and the finances of it. And Janet, I'm getting to your finances question right now. If other folks have questions that haven't been answered in the chat, please just raise them up verbally. Let's have an interactive here.
I have a question. One of the things that I'm getting ready to launch in our system is a shared medical appointment, collaborating with some other people in our system, especially in nutrition and behavioral health, and thinking about how the model where the doctor pulls people out for a couple minutes and does these appointments, the doctor doesn't get to have the fun and the joy of it. Although I think that this prescription for behavioral health is exactly what's needed for chronic patients. And I love the transdiagnostic approach. So it's not just a diabetes group or a depression group, or everyone can benefit from these 4 pillars that you're talking about. It's very powerful, and loving the way you guys do it. It's beautiful.
Thanks, Whitney. Yeah, There are some providers who, by virtue of their personality or their training or their humanity, are equipped to lead great groups, and they would be happy getting up and leading movement and mindfulness and talking about food and all of that. And part of what we found is that many providers were not trained to do that. They see the benefit of it, but they are not prepared to bring the circus to town, as it were. And so part of the virtue is the kind of like, circus in a package that unfolds in your clinic conference room or virtually, and that these coaches kind of do the whole thing, leaving the provider to operate kind of at the top of their scope, and just do the things that are really medically necessary. We have had providers who are like, yeah, we can do this, but I actually want to bring a resident in with me so that we can see 2 patients at once. Each of us get to participate in the group a little bit, sit with a coaching group, et cetera, and make it kind of more of an integrated model. And we're totally supportive of that as well. Elizabeth, go ahead. Looks like you have a question.
Well, good morning. And first, I want to congratulate you for your amazing work and presentation. I'm a physician who is certified also in lifestyle medicine. I do believe that Vermont has this infrastructure to produce an organization and make a system work like you. I know Kara very well. She's working very hard onto the health coaching model. And I've done the same also as a physician and producing, having help with the health coaching with primary care, share visit. But your organization and system seems that it has some amazing result, and with Rise Vermont as well into the Vermont environment. I do believe that looking at all the people that are listening to you today, that there's definitely a good future for that. And thank you for your presentation again.
Thank you. Lovely to be here.
Gary Nauman here. It looks like it's more challenging to get men to participate in the program. Have you been tracking your gender percentages to see how many men are actually involved in the groups?
You should look. Ben, do you know off the top of your head?
I don't know exact numbers on it. We definitely do have more women participating than men. I would also guess that part of that is just like willingness to participate in groups and what seems like it would be a good fit for a particular person. I suspect another part of it also comes from, as men, we are less likely to come into primary care. We're less likely to do some of the preventative behaviors that are good for our health. And so I think that part of that's going to be that we're seeing just more of those kind of broader differences between men and women as well.
Yeah, I just noticed that there was only one man in the participation group in the Zoom meeting, and just wondered if that was typical.
Yeah, it varies by group. It's funny, in one of our Spanish-speaking groups, it's entirely women. And once a group is all women, it's hard to have men feel comfortable. In other of our groups, there are more men. In fact, OSWX, the independently run peer group, I'd say the leadership of that is mostly men. So I'm not sure what to make of that right now.
Can I ask a quick question about children? We're doing some interesting work here in Vermont with Porter in Madison County and some pediatricians on integrating institutionally healthcare for children in primary education. So there's a very fast uptake on discovering adverse childhood experiences, trauma-informed counseling. Can you talk about how this program could be applied or is being applied as it relates to children in the, say, 2 years to 8 years old?
Ooh, good question. So we've done our first PEDS pilot. We were looking at the 9 to 12 age range. We haven't done younger than that yet. And it's not ready for prime time. We're still working that out, because part of what we find is that the family has to be involved. So just getting a young person on Zoom is not going to do it. We really sort of need it to be a family intervention. But stay tuned. Hopefully we'll have a PEDS program ready to roll out in the next couple of years. I want to be respectful of time.
Oh yeah, I was just gonna say another piece of that is we love it when families join. So while we haven't done a PED specific, we often have parents or grandparents bring children or grandchildren with them, which is always wonderful to see, and like to have that really intergenerational focus on health and well-being.
Thanks, Ben. All right, I want to just check in with Kara and Whitney. I know we are at time here. Anything you guys want to say before we close out?
Just thank you very much for the presentation. It's inspiring, and inspiring to me to try to translate this work to Vermont, and hope to be able to confer with you or consult with you over time, which would be great. Was really, really seems to be a meaningful experience for especially the patients, but the people participating as the coaches too obviously really get a lot out of this, a lot of joy. It's an anti-burnout activity, it seems
Absolutely.
like.
Absolutely.
Yeah. I want to thank you both for coming. It was, again, phenomenal. This is, I think, my 4th time seeing you present, so thank you. And just so everybody knows, we are talking with Liz and Ben about bringing something like open source wellness here to Vermont. So if you're interested, feel free to reach out, and I'd love to collaborate with more folks. And if a lot of people are asking about the recording, it will be on the UVM Integrative Health website. So if you want to share it with others.
Thank you so
Kara,
much.
maybe could you put your email up again? I know you put it up for folks a couple times, but having it right here at the end would probably be useful. I want to say thanks to everyone for coming today. It's great to share with so many folks who are really on the front lines of this work. It's because of the work that you're doing with your patients every day that we're able to make this possible. Thank you.
Thank you
Thanks,
so
Ben
much.
and Liz,
Thanks for being
doing
here.
this.
Thanks
Fantastic.
so much. Great to reach
I know
out.
that this is going on.